Good afternoon, everyone. We are delighted to have Professor Maria Tassianon from Antwerp with us today. She's going to give her keynote speaker right in the beginning before we start. And the keynote speaker and the keynote is on anterior vitreous detachment and how it influences our cataract surgery. Something extraordinary and out of the way. Maria is an excellent speaker, an excellent surgeon, and I'm sure we'll enjoy her talk. Please.
Thank you. Thank you very much, Keki. And I'm so happy and so honored to be here. And I would like specifically to thank Keki Mehta, who I know for many, many years. And I went several times to Bombay. It was almost my second hometown. And also operated there, life surgery, etc. It was a little bit stressful, but a very nice experience. And based on all those people who invited me and who believed in my new approach, I have now evolved also in my knowledge about what is behind the lens. And it's not a black box. There is really something that we have to think about and that we have to know. So it doesn't go forward here. Can you do it? Yeah. So these are my disclosures. I have intellectual properties in the back in the lens ring caliper, but also in laser technology, limbal niche replacement. The Berger space is a space that is, in fact, described in 1887 already. It is it is described, but just in one page, in one book, and that's all. And it was described by Berger, who is from Austria. But the most important person is not Berger, is in fact Uyghur. Because Uyghur, he described that little membrane, and I don't know whether I can show you that little membrane where the anterior hyaloid is attached, close to the posterior capsule. And that is in fact, that little membrane is in fact, the Uyghur ligament is in fact the ligament that defines the Berger space between posterior capsule, anterior hyaloid, and that ligament of Uyghur, plays an enormous role in our accommodation. If it becomes loose, you lose your accommodation as well. It's not the only factor that plays a role in accommodation, but it adds to accommodation as well. Now, one of my mentors was Jan Worst. Keki Mehta knew him as well, and quite a lot of people must have known him. He was a wonderful person from the Netherlands, our neighbors from Belgium above us. He was a wonderful person. I learned in his lab where the Berger space is, and that white space that you see in the middle, that is the Berger space. And it's then that I said, okay, that space is big enough in order to accommodate a lens. But I have to pay attention that I have not to make the lens too big, because it must be accommodated in a space between 8 and 9 millimeter in width. So that's the reason why I made the back of the lens 7.5 total width. So here you have it again, Uyghur ligament, attachment of the anterior hyaloid to the posterior capsule, and that is such an important ligament. That ligament is so tight that it doesn't allow cells to pass through it. So it is also a meshwork. It's a meshwork that prevents cells to go behind our lens. For example, in cases of uveitis, you will not have cells entrapped there unless you have a detachment. If you have a detachment of the Uyghur ligament, then you may have cells there. So now, how do we know that retrolenticular space of the Berger space? What is the best to say? Berger, you can use that space when you have still an attached ligament. Otherwise, it's better to use the retrolenticular space. To fill it, look very carefully here. You see the border of the cushion that is formed when injecting viscoelastic, and that is the limitation, that's the attachment of the ligament of Uyghur. So in fact, you can see it during surgery. If you look very carefully, then you can already observe that ligament clinically. You don't need very much sophisticated devices. But of course, it's easy for me to say that. I learned about the space of Berger by using the OCT. And the first time I had the OCT, embedded in the microscope, in the Zeiss microscope, was in 2015. And then I could, for the first time, convince the people and the audience, look, indeed, we have both capsules of the anterior and posterior capsule that are entrapped in the sulcus of the lens. And you don't need to have much more evidence to that. You glide both blades, the anterior posterior one, in the lens groove, and then you will have, little by little, you will have the lens really positioned, completely stable. And maybe those of the ophthalmologists who prefer most to use it are the vitreoretinal surgeons, because the visual axis remains clear, no adhesions of the iris to the capsule back at all. I have good news, is that Aravind will make that lens very shortly for India, and then I hope that I will also be able to coach the people who wants to use it here. So now the person who first defined an AVD in clinic is Emmanuel Rosen, also a very well-known person from the UK who had who developed so many new things. And in fact, the AVD, when you look at this, at the drawing at the right side, for your ease, I colored the anterior capsule in blue, the posterior capsule in red, and the anterior hyaloid in green. And you see that the green and the red never touch each other. So that means that if you have that without inflating that space, that means that you have a spontaneous detachment of your anterior hyaloid. And then we did, of course, a study to see patients older than 60 years, or in fact starting from 45 years. Well, we found out that the AVD is an aging process. Just like we have a PVD in the posterior segment of the eye, we have an AVD. I do not know yet whether AVD and PVD are linked to each other, whether it is a mechanism that is combined or not, or there is a difference in timing that I do not know yet, but it is quite interesting also to learn about that. Now here you see a patient who has a very dirty visual axis, and when you look only in the clinic, you do not know where those dusts are located. And when you do the OCT, you can see it. It is in the Berger space partially. Why? Because you have an AVD. The anterior hyaloid is loosened from the posterior capsule, so cells can float from the ciliary body, can go in that space. Also, of course, in the anterior vitreous, and that is, of course, not very important to know, but that means that the patient will have always a dirty vision, a blurred vision if you don't take it away with vitrectomy. Now, how do you recognize whether you have an AVD? You don't necessarily need an OCT. When you have, for example, this is a pseudo-exfoliation syndrome, when you have a capsule, posterior capsule, that is really floppy and easily snapped in your irrigation aspiration probe, that means that you have a floppy capsule. That's an AVD. That capsule is not supported anymore by the anterior hyaloid. So you know it just by looking carefully when you do your operation. And this is also the reason why young people in the beginning, they have tears of the posterior capsule, because they don't think about that that the capsule may sometimes not be very well supported. Another indication that absolutely is 100% sure that you have an AVD is when you have done your phacoemulsification and you see some fragments of the lens in that area. Normally it shouldn't be there. It can only be explained when you have no attachment of the anterior hyaloid, because the anterior hyaloid prevents the passing of those fragments to the retrolenticular space, unless you have an AVD, a total AVD, including the hyaloidal connection with the hyaloidal zonules. So that is absolutely sure. AVD is 100% there. And then another one, those who do routinely perform, look how you have a spaghetti-like distribution of your OVD. And that is because you have such a space, you can almost inject a whole syringe of your OVD in that space. So these are all things that are absolutely nice to learn and to know. Now you have sometimes in patients who have a pigment dispersion syndrome, you sometimes see a like of moon-shaped rim of pigmented deposits. This is a patient with deposits, pigment dispersion deposits, and AVD. The anterior hyaloid is very far in the posterior segment, and the pigment, of course, is attached to that. Middendorf described it as being at the posterior capsule. He was wrong. It is at the anterior hyaloid that the Middendorf is dot. Middendorf is a remnant of the Cloquet canal. So this was my message. I think that you can recognize, hopefully, when you look carefully during surgery, if you have a floppy capsule, if you have pigment dispersion that you see, if you have whatever, then you have, if you have lens fragments behind your lens, you have a posterior capsule, you have an AVD. Thank you very much for your invitation.
Thank you, ma'am. Thank you.
Thank you.
Can I just add one point as a retinal surgeon? Yeah. So I had last week a patient whom I did a retinal surgery, and we inject gas into the vitreous. So unfortunately, the gas went into the Berger space.
Oh yes, it can happen.
And then that was trapped between the lens.
Yes.
And that was like a nightmare case. So over the time, that C3F had expanded, and then it ripped off the full vitreous base, and I had a giant retinal tear.
Oh.
So just wanted to share with you, like, that space is actually there, and it's very dangerous, at least. So if you're injecting, if you don't inject straightly into the mid-vitreous, the gel, and you tend to inject in this space, you can have, catastrophes which can happen.
Yes, but it's interesting that you explain this. This is on. So it is interesting what you say, because I was always wondering, is it better for the eye to have an AVD or not to have an AVD? Does an AVD influence also retinal tears or whatever? I'm not sure. Yeah. I don't know. But it is interesting, your case, because in fact you had a giant tear.
Giant tear, yeah.
Okay. So I think that might be increasing the risk of, and not only PVD is important. So you have also to look at AVD.
Thank you very much for.
Thank you. I have to go. Sorry for that.
Please, please.
Next speaker is none other than Professor Keki Mehta. So Sir will be speaking to us about disc dumbbelling techniques and trans-iridial fixation. Sir doesn't require any description from me. He's like a stalwart in our ophthalmology. Sir, please. Slides, please.
That was interesting in the extreme. Sometimes you always wonder, the little black spots which you see are the ones which are knocking around in the Berger space. My name is Dr. Keki Mehta. My son Cyrus unfortunately could not be with us today because he's got a court case, but he's going to give his video, so I'm going to present them to you. So you really, I hopefully not miss him much at all. So I'm first going to start off with his talks, and his first talk is actually on using Gore-Tex for suturing the lenses. As you're aware, Gore-Tex is a material which is an expanded PTFE and has got a complex nature. And it's basically, they have got their own calculation. They have their own calculations. So we are going to, so essentially works out like a 7-0. So here you have a lens, and we are now going to use the Gore-Tex to and put an implant, a secondary implant inside. This is an AIOS 4-leg lens which you're going to be putting in. First we have to mark it on one side, on 2 millimeters on one side and 4 millimeter wide. And this is the reason why, and you'll notice it as I proceed along the lines. And you fit in a simple, straightforward tunnel. Dissect it out. And use these 25 gauge trocars which you just saw. You put in 4 of them, 3 at the side and 1 on top. Why not 5? Simply because then there's no place for you to put the hand in. Keep following it. Now here you got the back and IOL complex which has dislocated and is now lying on the retina face. We are floating it up using PFCL. It's the simplest way of handling a lens without damaging the retina in any way. Once you get it into the anterior chamber, the bag and the complex, as you notice, the whole thing had dislocated inside. The next thing which you do is you open up the scleral flap and you remove the lens. The temptation always is to remove both simultaneously. Try and avoid that, because then that stretches the opening, which you don't want to do too much. So the lens comes out first. You can see the left bag is left behind. And once that is out, then you do a little core vitrectomy to make sure that you remove all the adhesions which are there, and which is important, because the last thing you want is to develop adhesions at a later stage. More so if your bag has been lying floating around inside for a period of time. You finish this, and then comes the interesting part. The Gore-Tex suture which we are utilizing uses a 9 millimeter needle. Mind you, this is a sharp tipped needle, but it is round body, because Gore-Tex is usually used to suture blood vessels. Now this is an AIOS 4-leg lens made by Bosch & Lomb. And just follow it as you see. The Gore-Tex sutures are put through 2 ends on the upper side. And you pull it out. In a similar manner, you can then go inside and you feed it in, and feed the loops out using a microforceps from the trocar cannulas which you have already placed inside. That way you got your 4 loops out, and the final loop is being pulled out from the side. Most important at this stage, be sure not to get your sutures crossed. You cross them, you are in trouble. You'll have to start all over again from scratch. It's almost impossible to distangle them, as one would say, inside the eye. So fold it and slide your lens in. Now, the way to use this lens is to use a holder folder. If you remember the olden days, we had the holder folder. So you use a holder folder and fold the AIOS lens, so it goes through the 2.8 millimeter incision which has been made. And then you retract it in both sides. One big advantage of Gore-Tex, rather than utilizing Prolene, is Prolene tends to degrade over a period of time. Gore-Tex does not. With Gore-Tex, you know that it's going to last hopefully forever. So you made those 4 openings, and you use your sutures and you tighten it. Remember to use a double throw, because Gore-Tex unravels otherwise. Put your sutures on both sides and tighten them. And now rotate the knot inside. Two ways of rotating a knot. You hold the loop and you swing it, or you just hold the suture and shove it in. The second one is the easier. It's less chances of the suture opening by mistake. And you utilize then disposable sutures then to close it. So this is one of the simplest ways of handling using Gore-Tex. Finally you remove the little one on top, which was acted as your feeder to make sure the chamber never collapsed, and that is it. So Gore-Tex is a system which you should consider using. I agree that Gore-Tex is a little costly, but then you can cut it into little bits and use it over a period of time. Let me take you now to the next one, where we had a flanged IOL. The surface is all irregular, so we're going to scrape off the epithelium so you can see it a little better. And the whole idea is that we wanted to simultaneously put in the lens at the same time also do the desec. Why did we have to put the lens in? Because desec, if you're doing it without a support from behind, doesn't really work. You need to have a bubble to force it in place. So here we have the loops going inside, locking it into place. And the loops are then pulled out. These are 550 proline. This is being pulled out on both sides. And that's your lens. You utilize a low heat cautery to make sure you get a proper rock hold, as one would say. I'll talk about it again a little later. And then you move your lens into place and leave the proline loops hanging outside, and you utilize low heat cautery to seal it. Having done this, you put in a slide, then take your desec and slide your desec into place. Big advantage of putting the lens in at the same time is that the air bubble can be expanded. Almost in 20% of the cases, you may need to refill air bubble again, but it's a great method and it works simply and it works well. Let me now go on to something a little more interesting. I'm going to show you 3 different techniques. The first one, I don't think you have ever seen before, but you'll find it very interesting. Always the worry we have when we do a suturing of an IOL is, what are we going to do with the loop? Do we bury it? Do we make a little tunnel and we bury it inside the tunnel? Or how do we swing it? This is a simple way in which you can handle it. I call this as trans-iridial suturing. I'm going to have a small little, what should I call it, a schematic to show you exactly how this system works so you get an idea. It's a very simple system. Once you get the hang of it, doing it is chicken feed. A short animation. Essentially, what does this involve? If you see the lens, and you see the lens floating, you see it under the iris, you see the openings going through the sclerocorneal junction, and the lens is sutured in that place there, and remains stable. So this is essentially what you're going to be doing through the iris and through the cornea, lying in the surface of the cornea. Once you do this, the lens remains stable. So here you have a patient in which you're going to be doing it. You make a small little conjunctival incision on both sides to clear it up. And a little cautery to cut down any excess bleeding which is there. Now here is a microkeratome. Here is a diamond knife which has been set to 40 microns. You get 40 micron blades, but you can do it even by hand free if you wish, but this makes life easier. You make 2 cuts in the sclerocorneal junction. Be with me, it looks a little odd, but you'll find it a very simple method to handle. you insert your 90 prolene through on, pull it out from the other side. Essentially, you railroad it in, and then you hold it in the middle and remove the suture. This is the needle going inside, and through an alternate 27 gauge needle, you can railroad it and take it out. Withdraw the needle. And now hold your suture from the middle and simply take the suture out. It's a standard technique, nothing very great about it. The important thing about this technique is how you suture it in. The method of actually our old method which we do, and we use it and we loop it around and we suture it is fine. You do a double loop to make sure it doesn't slip. And insert your lens in. Now this is a Raynaud lens, and this is 6 millimeter lens. It's a foldable lens. A foldable lens, if you push it through a 4 millimeter tunnel, folds itself. You don't have to really fold it. All you have to do is to just hold the edges of the wound and push it in. So hold the edge of the wound, that's essential. A little opening extension is required, and then you just take the lens and you push it. Doesn't look great, but it's a very easy way of getting a lens in without having to expand it more. Just hold it and push it. Wait for some time, the lens will mold itself and slip its way in. The whole secret is to take your time. The important thing is not to push it. Let it go in, stabilize it into place. Drop your lens in. And then pull your sutures on both sides to center the lens, which it has. Now this is the interesting part. Take your needle and run it through the length of the opening which you have done. Subscleral, as one would say. At the start of the groove and ended at the end of the groove. So the needle essentially when you suture it, your suture will now go in the middle of the groove itself. You no longer have to worry about the suture coming out, the needle, and conjunctival flaps, etc. Really not required. Once you do it, you can just clip it into place and just push it into place. Once again, see it carefully. At the beginning of the groove to the end of the groove. And simply suture it there. This suture now goes into the depth of the incision. Nothing more needs to be done. Just have to juggle it a little to make sure it goes into the depth. It's never going to worry you again. Not visible, and that's a great way of handling it. And of course the conjunctiva, you can just pull it into place. I normally utilize a thermal cautery forceps, and which coaps the conjunctiva together. That usually is the end of this particular procedure as it lasts. Now let's go on a little more. And let me now take you on to the Canabrava method, which we are all aware about. But it's an ideal technique for subluxated lens. Now, it's a tricky way of handling it. I have made a simple way of handling this. I'm doing it. Just go through with me. You'll find life becomes simple. Yamane modification of the subluxated bag and IOL management using the Kana Brava.
Now what we are going to be doing here is utilizing proline, 50 proline to support the lens. Now this particular lens and the bag are both subluxated.
And the lens.
And if you notice the movement of the lens in the bag, everything is loose. You try any funny stunts and it's going to be sitting on the vitreous, making your retinal friend very happy.
Fixation won't be enough. The answer is simple.
Again the same procedure all over again. You just make a small little conjunctival flap on both
small
sides.
conjunctival flap is being lifted on both sides.
The reason why I put this step is because very often people tend to ignore it and say, no, we'll go straight through the conjunctival. Don't do that. Make your flaps. A little cautery to cut down on the bleeding.
Which may be there.
And then a 3.5 millimeter, 3 millimeter and a marker is utilized. And you want 3 millimeters on both sides. This is the reason why you will notice it in a few moments.
The zone through which you will be able to insert your needles so that you can, as one would say, bury the entire system inside once it is implanted.
Put in, most important step, put in an AC ventilator.
As it gives a stable chamber to handle.
Now move your needles horizontally. This prepares your Yamane tunnels.
You prepare the Yamane tunnels.
Just a horizontal needle opening. So this is ready for you when the time comes.
Now we need to
then you remove the Iol and the bag, which either way is not going to last there much longer. If you noticed, everything is loose and baggy. And once you cut down the flow, then you can put in the iris, which is tending to prolapse a little forwards. That's the whole bag which is removed.
And the air bubble is then subsequently inserted. And a single stitch is put.
I am an old-fashioned surgeon, so I like, whenever I open the eye, I want to keep it shut. I don't like keeping eyes open at any time, so I put in a cross stitch to make sure that the eye remains shut. And the next step which we do after this is
proline, the standard proline which we utilize for suturing.
Utilizing proline, you feed the proline into 27 gauge needles,
making sure that an adequate amount is
leaving just a little bit outside. And then you feed this needle through that Yamane tunnel which we had made, first horizontally and then vertically.
And then pull the thread out.
And that suture which comes out halfway, you pull it out.
This needs to be done from both sides.
Simple. Horizontally first, you remember you made your grooves first, and then vertically. Hold it and then pull it out.
Two loops of your proline.
Now you take a bung. Actually, it's the end of one of the rubber bungs. And in that bung, you just take two needles, same 27 gauge needles, and you punch a hole at the base of the implant where you want to implant it.
When you lift up the needle,
when you lift it, the implant comes on the needle naturally. Okay? Now, the same sutures which you took out from the eye, you now feed it into the needles.
Through the lens, at the haptic junction, you feed in 50 proline.
And then you take your lens, which has now been, as one would say, adfixed onto your 27 gauge needles, and just move it forward. So it comes off onto the proline loops. You no longer have to do any gymnastics to do it, it's simple. The proline which is out, you use a low temperature cautery and you heat it to form a ball. This locks it onto your implant.
This acts as your juncture point.
Put it to make sure it is properly stabilized, and then insert your lens inside.
Loops are not crossed over. Insert it in
the
a
opening
manner
which you have
in
made.
the lens lies posterior. When the loop is pulled forward, that prevents
You got your loops lying outside now.
pulling of the lens.
You can use a suture. 2 cross stitches usually enough.
Subsequently, in suture the wound with the running suture. This is a 10-0 running suture, which closes it. Now
And you make a
utilize
ball on both
the same
sides.
low temperature cautery and create a ball so that both ends are stable. Adjust it in place.
And that is it. Take your conjunctiva on top. Then you do a little vitrectomy, anterior vitrectomy, to be sure that there's no existent vitreous.
To remove any residual
You can
vitreous.
utilize a little steroid to make sure that there are no traces of vitreous which are present
And
there.
subsequently,
And then you take a coaptation cautery and just co-opt the conjunctiva on both
bury
sides.
the knobs on both sides.
And that is the end of this procedure.
Thank you for watching. This is a simple way of
as we
doing
can
a
do
good
it.
procedure and giving excellent results.
I will now request our next speaker, Dr. Dudani, who's a retina surgeon, who is going to talk to you on how he implants secondary IOL. The retina man is usually the fellow who is landed up with cases where someone has either broken the face, broken the lens, and they send the case across to him that now you fit a secondary implant, so he's now going to demonstrate how to do it. He's one of the foremost retina surgeons in Mumbai, though he looks very disarmingly young and quiet, very active surgeon. Dr. Dudani, please.
Thank you, sir, for your kind introduction. So, I think this is a medley of cases how we have tackled, secondary IOLs. So, IOL explantation and secondary IOL implantation, I have a few rules. Always expect the unexpected. If you're ready for it, then you'll be managing your complications well. And Murphy's law always applies in these surgeries that if something is going to go wrong, it will go wrong. And even there's a 0.1% probability of that happening. Never blame the cataract or the patient for the problems that you're having. Always learn to blame yourself if you want to learn. In a drop nucleus, always insert the IOL in the sulcus on the lenses. When in doubt, no IOL. In case of nucleus drops, don't fish for chips. Secondary IOL needs a very good anterior vitrectomy and also a good mid vitrectomy. That's how your IOLs stay well. Pass planner approach is the best for a vitrectomy. To do a good vitrectomy, use an infusion cannula or an AC maintainer. And there's a technique of vitreous levitation for IOL drop in mid-vitreous, where you don't have to drop the IOL on the retina and then pick it up. So these are the few choices of AC IOL. Has been a very, it's got a very bad name, but I think it's a very good IOL. If you do a good anterior mid-vitrectomy and do a good PBHI, it's a very excellent lens. Posterior iris claw is a good lens, but never in a vitrectomized eye, because your wound stays open when you're trying to enclave the IOL and hold it, and the eye the cornea just keeps on, collapsing. So in a totally vitrectomized eye, it's an extremely difficult lens to insert. I've learned it the hard way. Flanged IOLs, I'll describe to you a technique of what I use called as a dumbbell IOL. Scleral support IOL. PMMA on the residual capsule is a lifesaver. So go back to your PMMA IOLs if you have a residual lens capsule. A foldable hydrophilic lens, though my anterior segment surgeons will say no, 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 on the capsular rexus in the sulcus, does work very well and doesn't cause UGH or iris chaffing. And suture supporting in the bag. So this is my first video of, on an open PC, you can put a foldable IOL if you have enough rexes or a combination of anterior-posterior capsular support here. You can dump the IOL on the iris initially and then gradually and gingerly sort of, push one haptic behind and you'll be safe enough. This is another video of inserting a PMMA IOL onto a residual capsule. A PMMA IOL, which used to have the old-time IOLs, which are large IOLs, 12.5 millimeter. They lie very well in the ciliary sulcus, and if you gingerly put it over the residual capsule, you can have any anterior or posterior capsular remnant. You might not necessarily have a complete rexus also. So when you're doing a vitrectomy in these eyes, please try to preserve as much capsule as possible. It's very precious in these eyes. If you want to avoid these extreme maneuvers of, dumbbelling or doing yamanes. In this, it's better to flex and put the trailing loop rather than dial it, because there's a risk of damaging the zonules further. But if you're carefully dialing like I did in this case, you can manage to put the trailing haptic also over your residual lens capsule. So AC Iols are my favorite Iols because they, after I've removed a drop nucleus from the vitreous and I've done a vitrectomy, I've as it is spent 45 minutes for that case, and then you require patients to do another 45 minutes of suture support. So I have over time learned the trick of doing this IOL. Do a very good anterior mid vitrectomy, deepen your AC, and please keep the haptics always horizontal and never vertical, because when the lids are moving, that's where you get the pain for the patient. If you dial it very carefully, you have to flex the loops and dial it. As you saw, you can't dial it how you dial your posterior chamber lens, and these patients will give you a very rounded pupil, unlike the cat's eye pupil, which you might get more common in patients with posterior iris claw. Please don't forget to do a peripheral buttonhole iridectomy in these cases. It's mandatory. And I have a follow-up almost 20 years of these patients in my medical college where I'm working, and the eyes are pristine, and we have done a study on the endothelial cells also. So if you have sized your lens properly as per white to white, these lenses do very well. They have honestly undergone a lot of bad name, saying that it causes endothelial cell loss, but it doesn't. If it's a well vitrectomized eye, then the IOL stays very back, because of our incomplete vitrectomies when these lenses don't do well. I specifically wanted to show that PVI, you can do it the old way, or we as retinal surgeons can also use the vitreous cutter nowadays to create an iridectomy in these eyes. Another video of the AC IOL. You could also, constrict the pupil would be better in these patients. When you're inserting the IOL, it gives you a better sort of scaffold to put the lens very well. Suture assisted 10-0. Dialer. Alignment on the cornea. The trollicky surgery or the डोळ्याची होते. What is this? Lingayat. Suture system. Suture 10-0. So this is another case which we had, in which we had an opaque IOL. I had a high hopes that I'll get the IOL out without damaging the capsular bag, and I kept a PC IOL, but unfortunately you can see the whole bag came out with this IOL. This is the very few subset of hydrophilic lenses which became totally opaque. So in this patient now you can see that the whole bag with the lens is out. And when you have the bag with the lens, I think you've got to use a little more sturdier forceps, because this capsular bag tends to slip, with your Kelman. So you can also use the tooth forceps in these eyes, because with the bag, the whole thing becomes very slippery, This is the iris claw. One sec, sorry. So posterior iris claw is now the flavor of the season. But you can see this is one of the eyes where it's vitrectomized. You can see I've done a 3-port vitrectomy, So when you're holding the lens and the eyeball is fully full of, your fluid in these patients, your eye tends to collapse terribly, unlike when you have a vitreous-filled cavity, because your wound is going to stay open. You have to hold the lens while you're enclaving it, So this makes the whole thing, as you can see, how difficult it becomes in this situation to enclave it, because the eyeball is collapsing constantly, because the fluid is, though your infusion is on, you've got a fish mouth incision which you're holding the lens with, with that large forceps which you have. So you can see the whole eyeball is collapsing. I'm not getting a counter to do it. So I have a rule that in a vitrectomized eye, when I've removed a dropped nucleus from the macula, it's extremely difficult to enclave these patients. And you can see how floppy the iris is, and you can't enclave it. So it's really a tough ball game. But otherwise, in a quiet case where you've just done an anterior vitrectomy and the whole posterior vitreous is full and your eyeball is formed, it's a beautiful lens to insert, And please enclave very carefully the minimum iris at the base of the root, and don't go to the mid periphery, because then you'll get a proper cat's eye pupil, which looks extremely, annoying. So this is a difficult case because it's a vitrectomized eye. So again, I want to share with you, I think putting foldable IOLs over residual lens capsule is really, so you can see you can see the whole PC is open, so I'm using the dialer across to act as like, prevent my lens from getting injected straight into the vitreous and I have to remove one more IOL, So keep it there, dump the IOL over the iris and very gingerly sort of dial either the trailing loop or the leading loop over the residual lens capsule. So this is another technique which I've found is that, sometimes you can dump the leading haptic over the iris, and if you have enough capsule superiorly or temporally, you could trailing haptic first technique is what I feel, is that wherever the lens, the capsule is more, you first put that haptic over the residual lens capsule, and then you could do the leading haptic later. So I call this as the trailing haptic first technique, where you dump the leading haptic over the iris. So I think, iris can be a lifesaver in these patients and gives you time to sort of juggle your haptics over the residual capsule, the residual CCC, because in these eyes the pupil also doesn't dilate fully. You have to, sort of push the iris back with a Kuegelin's hook and see where the residual capsule is. So here I'm seeing, again I'm using the superior area of the residual capsule which was visible to dial the leading haptic back, to go reverse like. So this was one case I want to share with you also. One of my colleagues had done this iris claw, one of the hooks disenclaved, So then this is it became like a trapdoor IOL. The IOL was just flipping around with one haptic enclave this side, the other side wasn't. So I went with pass plan. I used my cutter to sort of lift it up, as a sort of, as a fulcrum, and I brought the trapdoor IOL up. Then I opened the wound which was already there, then held it with the normal forceps which we had, the old forceps, stabilize it, and then you could, rather than removing the lens or doing something else, you could just one side is enclaved, you could just enclave the other haptic. So this is a trapdoor iris claw reinsertion because one of the loops had disenclaved. Now you can see how, means in these patients, if you're very over exuberant during enclavation, you're seeing the level of iris damage which I've created there, So I think we have to be very sort of gentle. These irises are very fragile in these patients because they're re-surgery patients, most of them, So this is one case I just did last week. So, this was a drop, my resident dropped the full nucleus. It was grade 5 nucleus. Then he put the lens on the rexes. He said, I'm just going to put the lens. So now I'm stuck with removing this grade 4 nucleus from the pars plana region. And then I suddenly realized my sister didn't have the phaco fragmentation ready. Then I thought, okay, I've got Centurion. I'll remove the sleeve and I use the naked tip of the Centurion as a phaco fragmenter. But unfortunately, this Centurion machine is so sensitive and so emotional, like, I won't say like whom, but so it doesn't work without the sleeve, So it has got many sensors, so unless the sleeve is there, it won't work. Then I thought I'll cut the sleeve ka end and let only the hub remain and just I'll put the naked thing. But that also didn't work. It requires a full sleeve covering for the phaco to be activated. So I don't have any equipment. The IOL is there. I can't float the lens up. So I went with this full phaco with the sleeve into the vitreous, making a separate opening. I did a 23 gauge vitrectomy. I cleared the vitreous and the nucleus was lying at the macula. So I went with the full, you can see here, with actually the phaco probe with the sleeve. Now if you have the infusion of the phaco also coming, it tends to push the nucleus pieces away, So keep your infusion of your phaco off because you have your 3-port vitrectomy coming there. So there's a lot of chattering of the nucleus and everything. Then over the time, we managed to remove this grade 5 nucleus. So I just wanted to share this, Centurion phacoemulsification in the vitreous, I called it, yeah. So I think we retina guys can have a lot of problems. Thank you so much for your indulgence. Thank you.
Thank you very much, Dr. Dudani. That was very interesting. Our next speaker is Dr. Raghav Malik, who is from Center for Sight from Delhi, and he is going to be talking on secondary IOL implantation, gluing versus Yamane, in lieu of Dr. Sachdev Mahipal, who is at present tied up downstairs. Please,
Thank
Dr.
you,
Raghav,
sir, for
please.
this lovely opportunity. I will be speaking on glued IOLs versus the Yamane technique for secondary IOL fixation. Can I have my slides, please? So the indications for a glued or a Yamane would be intraopsonar ZD or a capsular dehiscence, not allowing a PCIOL implantation or a traumatic cataract or subluxation in the absence of a capsular support, traumatic aphakia and a complicated cataract surgery. Muffins, of course, is a big indication. Subluxated or dislocated IOLs, we can, of course, glue or do the Yamane technique with the same IOL. Aniridia with the cataractus subluxated lenses, Wheel-Marchesani syndromes, ICE syndromes, and bullous keratopathy with or without an IOL exchange. So the technique is pretty simple. You make sterile flaps at 1 millimeter from the limbus, 180 degrees apart. The tunnels are created. A sclerotomy is made from where the IOL is inserted. And then once the haptics are externalized, under the flaps, you can make scleral pockets with 26 gauge needles where the haptics will be tucked in. Once they are tucked in, the fibrin glue is applied and the tunnels are closed, and hence the lens is stabilized. A quick video will show the same. So the advantage is that once the haptics are tucked inside the pocket, they are not going to move, giving a good stabilization of the IOL. Though we have seen late decentralization of the IOLs, but in 95% of cases, they seem to work very well. This is just a schematic video showing the same. This is how the scleral pockets are made. Then we make a flap from where the IOL, a multi-piece IOL, is inserted. The haptics are externalized, and once they're externalized, you make small tunnels. This is just the haptics coming out. You make small tunnels into the sclera with a 26 gauge needle where the haptics are tucked in, and then we apply fibrin glue and close the flaps. This gives us good centration, and patients seem to do very well. So the glue is quick-acting surgical fibrin glue derived from human blood, hemostatic and adhesive properties, composed of two separate solutions of fibrinogen and factor 1, and fibrinogen is activated by thrombin to form fibrin monomers, which actually gives the adhesion. So the advantages are that the same IOL may be fixed in some cases. There are no sutures, hence no suture complications, lesser surgical time, and no separate IOLs with eyelets that are required. You can go in with a simple multi-piece IOL. This is a case where we actually had to implant a multi-piece multifocal IOL using the glue. So this is a subluxated IOL. We attempted to do a cataract surgery and put an ECR and put an in-the-bag IOL. But of course, Murphy's law does come into action. You do the hydrosection, you do a cataract surgery, try and put in a PCR. We're doing a cataract surgery. There is a nucleus drop. And once that happens, of course, the putting a lens goes out of the window. We have to remove the ECR also. Luckily, we could remove the ECR. We make the flaps, go in through the tunnels, do a vitrectomy, try and clean as much vitreous as possible. Remove the lens fragment, then put in a multifocal IOL, do a thorough vitrectomy, externalize the haptics, make pockets and tuck the haptics in. Then once you do put in the glue, and that's it. This is the glue being put in, and the pockets are actually closed. This is a well-centered multifocal IOL. Similarly, we have similar experiences with Marfan syndrome. This is, of course, us going in from the pars plana, doing a vitrectomy and removing the bag IOL complex. IOL put through the flap, externalizing of the haptics through the tunnels. We make pockets and put glue. Good, stable, centralized IOL. This is a week post-op. Intra-op complications can be trauma to the iris, dialysis of the iodialysis, hyphema, or bleeding. Vitreous hemorrhage, the haptics may break on externalizing. Ideally, a 3-piece or a Prolene haptic should be used. Post-op complications, hypotony, CME, subluxation, RDs, and haptic extrusion, which do require a resurgery. The glued IOL in a complicated situations could be new innovation with fibrin glue for IOLs with no capsular support. It is safe, stable lens with no IOL tilt faster surgical time with no sutures, no separate or different type of Iols required. Long-term results are still under evaluation. Coming on to the Yamane's technique, yes, this is a transconjunctival sutureless intrascleral haptic fixation technique for secondary Iol implantation. It uses a double needle technique with a 26 gauge needle to create scleral tunnels. The Iols are externalized with the handshake technique and flanged using a low temperature cautery, securing them in place. It is minimally invasive, reduces surgical time, and provides good stabilization. This is a quick video just showing how once the IOL is placed and the haptics are externalized with the cautery, the haptics stay within the scleral tunnels and give us a good centration and stabilization. If I quickly compare the glued and the Yamanes to compare and conclude my talk, the fixation with the Yamane is a scleral tunnel with flanged haptics. The scleral pockets with fibrin glue is used for glued IOL technique. So both are sutureless. The surgical time for the Yamane is definitely shorter. Stability is very, very good in our experience. The risk of decentration is much lower, and the learning curve is also flatter compared to the glued IOL. To conclude, fixating a PCIOL using a fibrin or a Yamane technique is a viable option in patients with deficient capsular support, be it primary or secondary. And after an initial learning curve, excellent results are obtained in terms of stability of the IOL, centration, reduced CME, elimination of sutures, and lesser surgical time. Thank you.
Thank you very much, Raghav, for presenting Dr. Mahipal's wonderful lectures. Thank you so much. Sorry we kept you back. I know you are tied up just now. Thank you so much for being with us. Our next speaker is Dr. Nivian from MN Eye Hospital from Chennai. He has a unique distinction of both being an anterior and posterior segment surgeon. Anterior segment from Aravind and from posterior segment from SN. He is the innovator of the CMT Flex lens and is going to talk to us on 4-year experience with the CMT Flex lens.
So thank you, sir. So I'm going to talk about CMT Flex IOL, a new option for aphakic treatment. So as you all know, like all inventions come with the question why. Can you play the video? Just a video. So you have seen all the different types of secondary IOL techniques that are there. And then what led to this invention is all of them are modifications using the existing IOL. So we came up with the idea, why not have a specific design of an IOL for aphakic management. So that led to the invention of this. As you have seen the various technique that was showed, the glued IOL, the M&A technique. So one thing for any secondary IOL is the 0-180 degree marking is very important, as you can see here, because that ensures that the lens doesn't tilt or you don't have any post-operative astigmatism. So here we make a 2 partial thickness 2 by 2.5 scleral flaps using the crescent blade, as you can see here. So this is basically to have the haptics of the lenses under the scleral flaps. So 1.5 millimeters away from the limbus, just make a 23 gauge sclerostomy. So in this particular case, we have the dislocated lens also to deal with, but being a very soft cataract, so what we did is we just held the lens in one side and using the cutter, just make a puncture posteriorly, and with the good aspiration and cutting rate, we made sure the entire lensectomy was performed. So we as retina surgeons know when it goes back, it becomes difficult. So this is the new CMT Flex IOL. It's a single piece hydrophilic lens design with specialized T-shaped haptics on either side. So the basic concept is this T-shaped haptics, when it is brought out, it just opens up and stays there. So it avoids gluing, tucking or suturing of the lenses. So here you have, through the sclerostomy, you have the 23 gauge Pranav forceps. So being foldable, you have another advantage of using it in any clear corneal incision. You don't have to open the old, if you have a scleral tunnel. So the only trick here is make sure the T haptic comes out first. So it makes it easier for you to grasp or hold the lens. So once you hold the lens, being a single piece lens, don't pull the lens out, because that's when it can break, and I have people telling. So inject the remaining of the lens. So that's the thing. So that make sure that the trailing haptic is either at the wound or over the iris. So once the lens is free, so now you gently pull it out. At the sclerostomy place, you're going to be a tug, and then you see there'll be a pop and open of the T-shaped haptics there. So that maneuver is called the PAP maneuver, pop after pull. That was also coined by one of my colleagues who's sitting here in the first row. So this is just a smart animation clip showing how it can just be loaded into any of the cartridge. So you can use any foldable cartridge. So you just use the cartridge. So you have the specialized designed Pranav T-Flex forceps. So you inject the lens inside. You can either grab the head or the neck portion of the lenses and then gently pull it out. So as I said, the 0-180 degree marking is the key, because how you're going to do the 0-180 degree, the lens is just going to sit there. So the lens does not depend upon how much of tucking you do. For the second haptics, it's easy. You use the handshake technique. You have those bridges there. So you just exchange it to the other hand, hold it, and then gently bring it out. As I said, because of the dimension of the instruments, you'll have a small tug there. So don't try to be very forceful, because that again, sometimes people say the other side slips. That is because we are putting excessive force. Otherwise, they sit in place. You can see we also have an angulation between the optic and the haptics. So that's the reason why there is no pigment dispersions, or you get these nice round pupils. And you can either glue the flaps, because the glue is just for closing the conjunctiva flaps. So you can suture it with observable sutures, or you can just cauterize it. So the glue is not the one that is holding in place. So these are some of the post-operative results that we have. We did studies about the UBM to show the position of these lenses in comparison with other lenses, and also OCT images through the sclera to see for long-term stability of these lenses over a period of 5 years and how it behaves under the sclera. So we recently have a publication of the 5-year results of a multicentric study. These were some of the case reports and other things in various journals. So this has been there for more than 5 years, and lots of surgeons have been using it. So I thought now it's time to tell about some of the tips that I can give them about a successful CMT Flex IOL. So initially we were using the 23 gauge needle for making these sclerostomies. So nowadays what I suggest is make a perpendicular incision to the limbus. So when your incision of the 23 gauge sclerostomy is perpendicular, the T haptics sit at 90 degree angulation. So that reduces the chances when you're pulling the other side of this slipping back inside, because initially we used to make the cut like this, yeah, parallel to the limbus, yeah. So the T also sits like that. So sometimes there are increased risks of the chances, or if it enlarges, for it to go inside. So other thing is nowadays we make it perpendicular to the sclerostomy. As I said, we have already given a 10 degree angulation between the optic and the haptic. So that's actually like a hammock. So that is marked by a small 2 holes that you see on the top right center there. So that gives you a clue while injecting. Sometimes the people say if the lens flips or this thing also, so you will know which side is the right side up. So you can see this like a hammock position that is there. Some of them hold that hole to also do the second haptic. The third trick is the head-on position. If you see in the first video, I would have grasped it by the neck. So what do you mean by the head-on position is when the lens comes out, you hold it at the head. So what happens here is when you're pulling it out of the sclerostomy, it actually the haptics bend inwards. So there is a lesser diameter of the lens that actually comes out. So that makes it easier and smoother for pulling out these lenses. Because when you hold it at the neck, you're having the entire bulky T that is going to come out. So you need to give more force. So we call this as the head-on position right now. So how you hold it. As I said, the dialing holes are there. I know some surgeons who have used the Sinskis or the dialers to use it. Initial days like Hausers and how we learned retropupillary claw lenses, some people put sutures through the thread on the trailing haptic. So they suggested it prevents the falling of these lenses initially when you're doing these secondary lenses, not having a VR backup. Complications, I think, yes, I should talk about it because it's common for all secondary IOLs. So this was one particular case when we tried to pull the other side. But then later we realized it is because the sclerostomy was made very large. So if you notice here, I'll just show you. Sometimes we tend to extend the sclerostomy. See that large line there. So two things you have, either you can make another sclerostomy, you can see the large sclerostomy anterior to it, or otherwise you can use the same sclerostomy and just put a anchoring suture. Yes. So I think after last time sir told me, I realized you can actually take it out of that and just put a cross suture that we used to do close the sclerostomies for 20 gauge retinas. So apart from that, as I said, again the head-on position is helped because it is easier to remove them out rather than holding the neck and trying to hold a bulkier portion out. So the common things that we get is the breakage of these haptics when you're trying to pull them out. Sometimes if you use retina forceps, sometimes any sharp forceps, because you understand these are hydrophilic materials, so sharp forceps can also bite into the material and chip it off. So this was another case, a patient who had a T-flex but underwent a blunt trauma. So he had an iridodialysis with vitreous hemorrhage with the dislocated of the lenses. So just to show that yes, it can locate and also, but it is easy like any other IOL that we pick up from the vitreous cavity. But here what I did is I didn't actually remove the entire lens outside, so I just exchanged it into the vitreous cavity itself using a chandelier. So I just wanted to just bring it out rather than explanting the lens and doing the whole procedure again. But I think either thing can be done actually. And I used the same sclerostomies in the first place, isn't it? Because the whole thing, it was because of the trauma, as you can see, the distorted iris and the vitreous hemorrhage, and it is not the sequelae of the uh, post-operative lens. So just to show complications can occur in any of these cases, but they are just common for most secondary IOLs. So in this particular case, because of the defect, we did the SFT, the single pass fourth throw pupilloplasty, and this is how the patient ended. So as of now, we have more than a 6-year follow-up period. So I'd like to thank Dr. K. Mehta sir for having me here. So thank you, sir, and thank you, AIOS.
Excellent presentation. I'd now like to request Dr. K.K. Mehta to share with us some more videos. Even there's no need for PBI because of the peripheral buttonhole aridectomy. You can't. There's no pupillary block in these patients.
So that's the reason why we have the angulation between the optic and the haptic. So block as such, and that's why the holes are also given for the deformation.
Okay.
So
the sclerosome which you made, what gauge?
23 gauge. You can just use the needle or the MVR. MVR is better because it cuts both sides and it is sharper. Perpendicular method is what we started using.
So this is the same lens which is being promoted by Omni, or is it a different?
No, it's a different lens. They call it the scleral tuck lens, I think, and the gauge is different. I think that comes out through a 20 gauge. This Apasami is actually manufacturing it.
Because the scleral tuck lens from Omni is having quite a lot of breakage issues.
They are 20 gauge, I think, if I'm not wrong. I think Patarana.
Usually go for anti-detecting.
Yes, sir. You can do. I have not shown. You can do, but always have an AC maintainer. See, this is common for any secondary IOL, as sir said. Good anti-vitrectomy is the key, and always have an AC maintainer or a trocar maintainer.
Yeah.
So the biggest this thing is if the eyeball collapses. So that's when we find it difficult to do any secondary IOL procedure.
Any tips on the biometry for these lenses?
As of now, see, we have derived at an A constant 118.0, so that is what and we have an optical A constant and immersion A constant. And that's it. It's in the same thing, so we don't minus or what you maybe okay. What you're asking is we don't subtract the power or anything. We assume that it is there in the position of the PC lens. Sir.
Yeah, Dr. K.K. Mehta, please.
Well, I'll now, one of our speakers has not come, so I'm going to compensate for him, hopefully. I'm going to talk to you on back to the wall technique of suturing IOL in the capsular bag in case of Marfan's. You'll find it interesting. Here you can see the lens beautifully dislocated, no question of any doubts about it. The question is, how are you going to handle this case? Make a diamond knife, and we enter, of course, a 2.2 opening at the side with the diamond knife, and the next step is that we have to now empty it out. So what we try and do is we try and move it, and we notice that it is quite, as one would say, beautifully dislocated. We make a small opening in the capsular area. And do a small little rexus. Once the rexus is done, the next step is usually these lenses are very soft, so removing them is fairly simple. But once you get rid of the rexus completely, the next step, of course, is that you have to use hooks to stabilize your lens. So you use capsule hooks, put them in at 4 points, and through that same little capsulectomy which you have done, you hook it on. Capsule hooks are longer. I don't like them because they tend to snag more, so I usually tend to use regular hooks. Once you do that, the lens stabilizes in place. The next step is a little hydrodissection, gets rid of the lens, comes out in front, and very low, as one would say, low flow phaco to get rid of the nucleus which you have managed to remove. So far there's nothing very interesting until the end, where I'm going to show you how to use that. Clear it up completely. Remove whatever residual cortex is there, because the next day it will float in the middle and creates a nuisance. Then we take a capsular tension ring and inject it in. The secret is to inject it from the point at maximum deflection downwards. So that is then pushed into place when you inject the ring. Make sure the lens is properly dropped into place, and that then stabilizes it. Now comes the interesting part. Just watch it. It's a needle. We put it through the injector. This has got a needle with a proline already on it. And you tie the proline, and first you push the proline needle out and pull it out. Next you tie the proline to the end of the lens which you want, or whatever type of lens you wish to inject. It doesn't matter which one you use. Having done that, trim off the extras. Push your lens in, and now all you have to do is, this is a regular injector, which Care Group injector is given with any lens, but any injector works equally well. Leave the trailing loop outside. First pull the needle out, and as you advance it in, so you got a needle outside, and you got the lens, and you got the needle suture at the end of the lens. Now you take your needle through the capsular bag and out through the sclera. Now you inject the lens inside. At the same time, maintaining a little traction onto the proline loop which you got in front. So you got the lens in, you got the suture on the end of the lens, and you're putting your loops inside, and you're putting your lens inside. Put your lens into the bag which you found. Now what you need to do with this is not to do anything dramatic, just make 4 passes through the sclera. You can either do that, or you can put a single suture if you desire. Both of them work equally well. But after you put the passes, just remember to put one last suture to be on the safe side. Remove your capsular bag, again, your capsular hold rings, and then gradually pull the suture forward as you are doing it, which will bring your lens into place. This is a simple, straightforward way, no gymnastics, no difficulty, anybody can do it. After 2-3 passes, you then place a single suture to make sure it remains locked into place. Adjust it a little to make sure it is properly set, and that is it. So you have, this is one way on which you can suture your lens in without any difficulty, and that's how it lasts. An easy technique. Dr. Dudani, you're next. Thank you for your attention.
Go to hall or awards. I'll take this.
another technique I want to just share with you all, which I learned. So like the CMT flex. So any foldable lens can be made a scleral flange lens, the Prolene dumbbell way. So PCR and vitreous loss always comes unannounced. Anterior vitrectomy done, but poor capsular support, unlike the previous cases which I showed you where there was no capsular support. You can't keep a battery of Iols all the time ready, AC IOL, iris claw, 3-piece for Yamane. Hence the need for a method where any single piece IOL can be converted into a scleral tuck IOL. The principle is creating a transscleral plug on the haptic for scleral support. So you can promise your patient like a premium IOL syndrome you have nowadays, trifocals, EDOFs. And so this is the idea came to me from the Carle-Vale lens, which is a very expensive lens described by a French surgeon, and the CMT flex which Dr. Nivian showed. So the worst kind of lens to have during a rent is a single piece, but you just require a suture with you. Nowadays I moved to a 7-0 or a 6-0 Prolene. So you create a dumbbell outside the eye by passing a suture, and then you exteriorize this dumbbell like a Yamane technique under the scleral flap. So you'll inject a lens like this way. So how do you create that dumbbell? So you mark 3 and 9 o'clock, do a limited peritomy, and use a angled sclerotomy with a 23 gauge MVR, and this IOL is injected over the iris. So I'll just show you with a video how it is. So this is how you create a transscleral. So you pass the suture, a 7-0 Prolene. This is a typical suture support IOL which you have from Orolab, the scleral support with the 2 holes in the haptic which you are aware of. So you create this dumbbell on both the haptics. And so this video is showing you how the lens has been created. So you're pulling out one stub of the dumbbell out, the second one is holding the haptic inside, You exteriorize it from that groove which you have made in the sclera, and this is the trailing haptic similarly. So this avoids your multiple sutures which are running across, in these patients of suture support, you have all the time, I think your sutures are getting jumbled. If anybody says no, I will disagree. I think you don't know which suture is going where. So here I've created a sort of a Nivian IOL, you can say, using just a Prolene. And then you just exteriorize one part of the dumbbell, the inner part holds the haptic. And this can be also used, I tried it for a patient of a single piece foldable IOL, which we normally use, like the foldable IOLs which we have, typical ones, And you can pass that needle, it's a round body needle of a 7-0 Prolene through the haptic. So this I just wanted to share all. This was like, it is difficult to exercise, but over the time when you learn, you can, with the handshake maneuver, you can feed this haptic and you can exteriorize it. It will come out. This was my first case, so it was definitely a learning curve. And this is a foldable, this is again that similar lens which I've shown you all. This is another case I'll show you where a foldable lens has been used. So we had this, all the Prolene sutures over the time degenerate and they tend to fall down, as you have seen in this patient. So this we have explanted the IOL. And this is what I want to show you all. You can use a single piece foldable lens to create that same dumbbelling here. This is a much larger needle which I used for a 4-0 in the initial stages, but now I'm using a 7-0. So you can pass it through and you can create a dumbbell. So you could use it in any of your foldable lenses which you had pre-op when you had a rent and you don't have the other armamentarium. So you can make any of your lenses into this dumbbell lens, and there is a definite learning curve which I don't deny initially, but you can sort of learn it. So this was my first case, and again you dump this IOL over your iris because there's no support at all behind. You don't want the lens to go in. And then each haptic is exteriorized, as you can say, and then you can further diathermize it like how we do in Yamane's technique to get a thicker dumbbell. There it is, yeah. And then you can dump it in the scleral groove which you have made there. So the point was that I can have a lot of, yeah, you can. So this is a post-op photo, okay? So this is a big dumbbell there which might cause a little bit of conjunctival sort of, you know, erosion. I agree with you, but this was my first. So last video, so we as retinal surgeons, we normally get, you know, these cases where there's, you know, a partially subluxated lens. As you can see, it's visible. So initially we used to be very purist and all. We used to drop that lens over the macula and then go in with a phaco-fragmentation and get it out, you know, because, but here this, I wanted to show you a way which you can do it without dropping the lens inside. So you use this MVR blade to sort of levitate it, you know, what I call as vitreous levitation of this. And then I'm using a vectis here to levitate it. Then I will open the incision and you can deliver the nucleus without dropping it inside, you know. Though I was ready, you can see I've got my pars plana infusion inside and you could, you know, be ready for this, but why do you want to drop this nucleus when it's waiting for you to be taken out, you know, anteriorly? And we have always used vectis and ICC for a subluxated cataract. I have done it like in my initial days, but nowadays, like, you know, so you can use this procedure and sort of deliver that. Now I had only one vectis, so I had to shift that vectis from there and use this same vectis to deliver this nucleus out, the full cataract. And then we do a generous vitrectomy. And here again I wanted to show you all that we did in this vitrectomized eyes, we used a iris claw here. But as you can see, if the wound is open, it becomes difficult, so you have to plan it initially. I was planning an AC IOL, but my colleague said, no, you put an iris claw in this. You know, I think you all don't, AC IOL would have been a miracle in this eye, you know. I mean, you just do it because it's a vitrectomized eye. And in a soft eye, iris claw with an open wound is a difficult thing to do, as you will see, you know, in this. If I put the infusion on full, the iris comes out, you know. And if the eye is relatively soft, you can't enclave it that well. But we managed to do it, a posterior iris claw. So thank you. Thank you. Thank you. Yeah, because we didn't have that. I think those other cauteries are not available anymore, you know. So the heat cautery works equally well.
Would like to
Yeah.
thank you all very much for being with us today. And I
Thank
hope
you.
you enjoyed. We tried to get as many complications as we could so that you'd be able to handle it at your own time. Thank you so much for being with us.
Thank you.
Hopefully you will get a chance to do a course again next year.
Nivian, I'd like to give you some, please leave the memento.
Yeah, come.
Yeah.
सर તમને એક આપું ને
Thank you.